Hi friends, today I will be discussing about constipation in children. Child who is around 3 to 4 years of age with a history of very large hard palate like stool. A common complaint that parents say is that the child tries hard to pass stool but is unable to pass. They give a history that the child typically strains while passing stool, and they also give a history that when a child strains to pass stool, it tightens its buttocks. In my day-to-day practice of pediatric OPD, I usually come with parents who has children of 3 to 4 years of age with a history of very large hard palate like stool. A common complaint that parents say is that the child tries hard to pass the stool but the child is not able to pass the stool. They give a history that the child typically stands while passing stool, and they also give a typical history that the child is trained to pass stool and it tightens its buttock. A simple definition of constipation would be any difficulty or delay in passage of stool that causes significant distress to the patient. The constipation can be two types. It can be functional constipation or organic constipation. So what are the etiology of constipation in childhood? We know that 85 to 90% of the constipations are usually due to functional reasons, and 5 to 10% of the children have organic causes of constipation. Another important point to remember is that the organic causes of constipations are more common in infancy. If a child has onset of constipation early in life, early in infancy, we should think about some organic causes, whereas functional constipation tends to occur a little later in childhood. A simpler definition of functional constipation is a constipation occurring in children above 3 years of age, lasting for more than 2 months duration and not explainable due to any structural, anatomical, physiological or histopathological abnormalities. So most children with functional constipation do not have a known cause. We do not know why they become constipated. So what more do we know about functional constipation? Functional constipations are more common in boys than in girls, and the peak age of onset is toddlers and preschool age, which coincides with the time of toilet training. We should know that a number of children with functional constipation, if left untreated, go to remain constipated even during puberty and older age. So what is the typical history of a child with functional constipation? Usually a child who is around 3 to 4 years of age with a history of very large hard palate like stool. A common complaint that parents say is that the child tries hard to pass stool but is unable to pass. They give a history that the child typically strains while passing stool, and they also give a history that when a child strains to pass stool, it tightens its buttocks. This behavior of the child is perceived by the parents as a genius effort by their child to pass stool, but that's not true. On the contrary, we all know that if we stand, we cannot pass stool. If it tightens his buttocks, the child is actually trying to withhold the stool because of fear of defecation. So what has happened is that the child had a painful bowel movement, and in order to avoid painful movements, he has developed this habit of withholding the stool, and this over a period of time may even lead to certain complications like a fissure. So the child may present with you a few streaks of blood in the stool. The common history is that the mother tries to treat the condition with dietary measures which never work. They go sometimes to doctors and they give laxatives which again do not work. Sometimes when the child presents to the doctor, they may actually be having a blockage in the intestine which is called a fecal impaction due to this chronic constipation. And it is important to recognize that we need to specifically treat these children for fecal impaction before treating with a routine laxative therapy. The first question that most parents ask is why my child developed this constipation. Usually remember, every chronic constipation starts acutely and what is the trigger or the event that leads to the child to become constipated need to be investigated. The trigger could be some form of a minor illness, maybe a viral fever or some other illness. Sometimes many medications including certain drugs like iron supplementations, cough syrups, or some sorts of medications that can also and some other medications can also lead to constipation. Sometimes a recent history of travel may be there, or a recent change in dietary habit, or a recent change in weather can also lead to constipation. It is not very unusual for somebody who travels about 2 days on a bus or a train and goes to another place and become acutely constipated because they do not like the toilet there. Sometimes it may be something as simple as the children do not prefer to use the toilet in their school because they are not clean. And sometimes you may see that the child gets up very late to catch the school bus and does not have enough time in the morning to go to the toilet before they can catch the school bus, and during the day they tend to withhold as they do not like using the school toilet, and this leads to a pattern of constipation. So what is the pathogenesis of functional constipation? As a parent, it is very important to understand the pathogenesis of functional constipation so that they can understand how to toilet train their children. Whatever may be the reason, there may have a painful passage of stool, and there may be history of painful passes for a few days that can result in a very minor mucosal break on your child rectum. This painful mucosal passes the child perceives is enough for the child to basically withhold the next stool. Once the child starts withholding the stool, there is a lot of fecal retention in the anus. We know that the purpose of the colon is to absorb a lot of water. So the longer your child retains the stool, the harder the stool becomes, the drier the stool becomes, and the larger it becomes. The next time you try to pass the stool, it's going to be more painful than earlier. This over a period of time is going to lead to a large capacious rectum, which we call the megarectum. So once a megarectum is developed, the normal urge to defecate also decreases because you don't sense that your rectum is filled with stool. That is the reason why when you start treating constipation in a child who had already achieved megarectum, laxative therapy needs to continue for a long time, several months to years, before the megarectum regains its elasticity as well as the urge to defecate is perceived by the child. Once the parents understand this, they will be more compliant with the medications. Otherwise, what will happen? They will not continue the laxatives for a long time. So it is very important. We should tell them the pathogenesis of functional constipation and about fecal impaction and formation of megarectum. What are the common organic causes of constipation that we need to remember? Hussein's disease is a very common condition which can occasionally present with an early onset of constipation, and they usually have a history of delayed passage of meconium and abdominal distension, and as well as failure to thrive. Anal stenosis is another important cause of constipation. We need to do a very careful perianal examination. A number of children with anal stenosis may be missed initially in the first 6 months. The anal stenosis becomes more evident when the child go on to solids, and that is when they manifest with constipation. Certain drugs can cause constipation. A history of drug intake is very important because sometimes many children on iron supplement as well as on antidepressants may tend to have constipation. Hypothyroidism is another important, very common cause of childhood constipation. If you have a child who is short stature, not growing in height, suspect as an occult hypothyroidism as the cause of constipation. Neurological causes like meningocele may sometimes present with constipation. Finally, along with the perianal examination, we should examine the spine of the child also for any tuft of hair or any neurological causes that may predispose to constipation. So when we suspect organic cause of constipation, we suspect organic causes of constipation if there is a history of delayed passage of meconium. Secondly, if there is an infantile onset of constipation or early onset of constipation, that is a clue for an organic cause of constipation. And the presence of significant abdominal tension or failure to thrive should also make us think about organic causes of constipation. And most importantly, absence of any classical features of functional constipation should lead to organic causes.